students in the classroom than our regular classes. So if you get quiet, we can try to finish this before 6. I don't think it's going to be taking 2 hours, but we'll try to finish it as slowly as necessary. But before we start with the review, I'm going to show you what happens with the quiz. As was requested by the class, so I'm just putting okay, I hope you can see the password. Here's the password. Here's the password. So write down the password. Has anyone given online quiz through ExamSoft so far?
Yeah.
Okay. So it's going to allow only 12 to 14 hours. So look at the download time. It's going to be starting at 1 a.m. if you want to start downloading. But the actual quiz should be starting from 9 a.m. on the 4th of October. On the 4th of October. And you should be able to finish it around midnight. So you have about 15 hours of time to finish it. So you're going to see 20 questions, total of 20 questions in that quiz. It's worth 4 points, total of 4 points. It's an online quiz. Just to give you an example of the type of questions that are going to be on the exam. So I'm only hoping that everything will work without any glitches and you should be able to take the quiz. So this is the best I could do. We tried all other avenues and finally we decided to give the quiz online, which is going to be available for at least 14 to 15 hours. Any questions related to the quiz?
Is it going to be hard?
Well, you'll see it. Yeah. If you're ready for the exam, it should be very easy. If you're going to study on Thursday, just a day before the exam, it's going to be not an easy quiz. So, what we are going to do is, we are going to start with some kind of review. I'm not going to be telling you what kind of questions are going to be, what questions are going to be on the exam, but I would be giving you some kind of hints related to what should be, covered first when you are preparing for the exam. I would say everything is important, but you focus on the things that I'm highlighting today. This would include all the information that was added in the classroom, not just information that is given in the handout. Whatever was added in the classroom are important. We'll try to cover them as much as possible. Basically, this is to help you to better prepare for the exam. So after going through all the strategies that I'm recommending, if somebody comes to me and says, oh, I was not able to get 100, I'm not helping you to get 100, I'm helping you to really get ready and pass the exams with least amount of difficulties. So the way normally I do the review is going over the pages one by one and highlight the most important information. I hope that strategy would work.
Yes. The best strategy.
Very confident, yes, in the back.
Okay, so when it comes to the environmental factors, I showed you a video using phytochemicals and natural products. There are going to be 2 or 3 questions related to those aspects. Number one is, Lycopene can be found in what source? Tomatoes. Resveratrol can be found in what?
Wine.
Grapes. Genistein can be found in what? Genistein. Soy products. So remember those kind of things. And also, I gave you the ranking of the natural products with high levels of ORAC value. So remember the top three. Remember the top three with the highest ORAC value. And what are the three species of oxygen-free radicals? Hydrogen peroxide, superoxide, hydroxyl. Which one is the most reactive? Hydroxyl. So remember those aspects. And when it comes to vitamin A, vitamin C, green tea is how many times more potent than vitamin? Does anyone remember? 500 more potent than which one? Which vitamin? Vitamin C. And 10 to 20 times more potent than vitamin E. So remember that. Vitamin E and selenium will help glutathione peroxidase. Glutathione peroxidase. So I kind of, so these are the free radicals. So you remember those free radicals, glutathione peroxidase. So before I go into the hereditary factors, in terms of the statistics, we covered some of the statistics. How many patients die in a year in the US? Approximately 560,000, close to 600,000 patients die. And also there was a chart where cancers with top 3 incidents among males and females were given. Look at that. And also look at the chart with the number of deaths, the maximum number of deaths caused among males and females. So I'm not going to repeat because it will cause confusion in your mind. Go back to the notes and look at the top 3 in terms of causing incidents and top 3 that is causing death among males and females. In addition to that, we looked at the cancers which are very easy to treat, the top 3 cancers, and the top 3 cancers which are very difficult to treat. So remember those 6 types of cancers. You might be able to answer one of the questions. So now go to the hereditary factor. So definitely there's going to be one question related to the breast cancer causing mutation, which is the BRCA1, and then FAP, Wilms tumor, WT1, and retinoblastoma. When we were talking about CML causing translocation, we also discussed about the inhibitor. What is the name of the inhibitor? Does anyone remember?
No.
The drug which is inhibiting the ABL-BCR.
The M12?
Gleevec. Remember, not only the name, it is going to be specifically inhibiting the ABL-BCR kinase, Gleevec. And I also said that's one of the drugs which can show improvement in the genotype of the patients. So in a nutshell, this table and also the translocation between the 2 chromosomes and the type of kinase that is produced is ABL-BCR kinase. That should be remembered. And the drug is Gleevec. Gleevec. So just remember this information given in this page, because there is going to be one question the most difficult thing is whatever is at the very top, whatever you see here, occupational hazards. So that is what you need to memorize. Everything else is in a common sense. So if you memorize this, you might be able to answer one portion of the question. And then low or zero parity would increase the risk for developing ovarian cancer. Ovarian cancer. Late pregnancy or no pregnancy is going to increase breast cancer risk. Zero or low parity will increase ovarian cancer risk. When it comes to drug-induced cancers, lupus drugs. I mentioned about lupus drugs. You remember hydroxychloroquine and prednisone? The combination will increase the risk for developing breast cancers and leukemias. So remember that. And then the question in general is going to be related to the theories of the cancer. Number one is going to be asking you about which population would have high levels of free radicals. It's going to be children, young population, or geriatric population? Right. So there is accumulation of free radicals as individuals get older. So this is the basis for gene alteration theory. Don't memorize things, but try to understand what is the basis for gene alteration theory. And then there's going to be a question related to this experiment. Basically, when you take the nucleus from the cancer cell and then put that in the cytoplasm coming from the fertilized egg, if the normal tadpole develops, would that indicate mutation in the nucleus? No, there's no mutation in the nucleus. So that is the basis for answering the question related to this experiment. So if the normal tadpole develops, there is no mutation in the nucleus. On the other hand, if it is dividing uncontrollably, then you can say there was mutation in this nucleus. So there is going to be a question related to this experiment. So from there, if I'm skipping, doesn't mean that you can skip the pages in between. What I would do is I would focus on the things that I'm highlighting today, and then when you have time, you can look at other information. So when you are looking at the oncogenes and the products, I told you to remember the names of the oncogenes, which are on the left-hand column, the first column, and also the products. It would help, for example, HER2 would induce breast cancer. That kind of, general information would be helpful. Whenever there is HER2 gene, then you are going to see EGFR expression, epidermal growth factor receptor expression. So I did not discuss about the drug that is normally used for treating HER2 positive cancers. I'm not going to be asking any questions because I'm in the process of eliminating those kind of questions. Whatever was not covered, I'm not going to be squeezing your brain with questions related to that. So when it comes to, I don't have the chart, but we discussed about the P53 related mechanisms. So if you are looking at the DNA-dependent kinase, that is going to be phosphorylating what? Or it may say ATR kinase or DNA-dependent kinase. That is phosphorylating what? Anybody? P53. P53 will be inducing the transcription of what gene? P21. P21 would be inhibiting cyclin-dependent kinase. cyclin-dependent kinase normally will phosphorylate retinoblastoma protein, RB protein. So remember that part of the pathway. It will be good for answering one of the questions. Starting from the DNA damage, look at what is the sequence of events. So that will be helpful in answering one of the questions. So in relation to angiogenesis, we talked about the role of angiogenesis in the metastatic process. Remember, we talked about micrometastasis, which is kept dormant. And that dormancy was induced by what protein? Do you remember what protein? Endostatin, right? Endostatin was mentioned during the discussion. So endostatin will keep the micrometastatic growth dormant for some time. When the primary tumor is removed, endostatin is gone. Now cancers will appear in multiple locations of the body. Okay. So when it comes to staging, definitely there's going to be a question. One or two questions, either in the quiz or in the exam. One is looking at the score and then decide which one of the score would give either the very poor prognosis or the best prognosis. I would look at the M score first. Higher the M score, poor prognosis, and lower the M score, better prognosis, and then you can go backwards. T3 means what? When the score is T3, the cancer has gone into bones. All right, now, when you go to this growth fraction and doubling time, there could be a general question. Which one of the cancers are going to be responding more to chemo? Ones with large growth fraction or smaller growth fraction? Right. So that's what you are going to remember and have a general idea about what is the doubling time. And then here, now it is possible to have some kind of numbers related to the log kill potential which is coming next to this. But here, debulking is the strategy that is very useful if you are treating large tumors. Without debulking, treatment would become very, very slow and sometimes ineffective. So remember that. So when it comes to log kill potential, count the number of zeros. And the difference between before and after treatment should give you the number of log kills. You don't need a calculator. If I give you the number, look at the number of zeros before and after treatment. The difference is the log kill potential. What is the minimum log kill potential that is required? 3, minimum 3. If you go higher, more toxicity. If you go lesser, it's not going to be effective for controlling the cancer growth. So multi-drug resistance is induced by which protein? P-glycoprotein. P-glycoprotein. And that can be inhibited by verapamil and quinidine. If you look in this paragraph, you will see verapamil and quinidine that was mentioned. So that can kind of overcome the resistance caused by multi-drug resistance protein. And which two drugs will induce multi-drug resistance? You have the names of the drugs in this page. Taxol. And then what else? Doxorubicin. Do you have doxorubicin? Okay. Taxol and doxorubicin. You don't want to combine those two because now the chances are more for inducing resistance. So not only the combination rules, the rules that are given as 1, 2, 3, and 4 are important, and also the three types of combinations. Combinations inducing sequential blockade, complementary, and concurrent. So remember those. So I've given specific examples, so there's going to be a question related to this. When it comes to complementary, methotrexate complements 5-fluorouracil effect. That's what you would remember. When it comes to sequential blockade, 5-FU complements RSC. And the other one is 6-mercaptopurine monophosphate and 5-FU. So 5-FU is in all three combinations. It's a hint for you. 5-FU is given in all three types of combinations. All right. So from there, so when somebody enters into blast crisis, you may have this. When somebody enters into blast crisis, typically how long do they have? Approximately how many months do they have? About 6 months. So remember that. And also I mentioned about progression-free survival in multiple scenarios. So when they are looking for PFS, progression-free survival, what is the minimum expectation? How many months? That is also 6 months. If FDA is going to approve any drug just for extending life, we are looking for minimum 6 months of life extension. So the reason I'm mentioning 6 months is somebody goes into blast crisis, they can live 6 months. Some people may live a little bit longer, but 6 months is the typical life expectation. FDA can approve the drugs if it gives minimum 6 months of life extension. All right. From here, I'm going to go to the warning signals. When you look at the warning signals, read it carefully. I will be asking you to identify 1 or 2 warning signal that is wrongly stated. So read the sentence carefully. Read the signals carefully. Whichever is correctly stated, put a tick mark and identify the ones which are wrong. So I cannot give you any more hint than this. All right, now 3 goals of treatment. Remember the 3 goals of treatment. So I don't need to repeat anything here. Remember the 3 goals of treatment. Palliative treatment is pain management. Surgery is not only used for treatment purposes, it can also be used for palliative purposes. It can be used for reconstruction. Examples are reconstruction after mastectomy, reconstruction after facial cancer treatment. So those should be remembered. When it comes to radiation, which range of radiation is the most effective for killing the cancer cells? Which range of radiation? 5,000 to 6,000 rads. So the list of radiation doses given, pick the 5,000 to 6,000 rads. That's the most effective for the cancers. So I remember I told you that try to memorize, even though some of the drugs, for example, vincristine, vinblastine was not covered in detail. I told you these are plant alkaloids. They are specific for M phase. So memorize the drugs which are specific for phases, different phases of the cell cycle. And you will definitely have one question. Don't forget the hydroxyurea topotecan procardicin. These are specific for S phase. And prednisone dexamethasone. This is specific for G2. Forget about asparaginase. Now, we did not talk about asparaginase. I would not worry about asparaginase.
Oh, asparaginase.
I'm sorry, G1, sorry, G1. Not G2, sorry, G1. G2 is here. So there's going to be a question. Why BMS is more with nitrosoureas? The answer for that, can anybody give me why bone marrow suppression is more for the nitrosoureas? Because it will be attacking the cells which are getting ready for cell division, which has the potential for cell division, but they are resting. So bone marrow cells are something like that. They have the potential for multiplication, and because of that, you are going to see bone marrow suppression more with the nitrosoureas. So when we go to the nitrosoureas, we'll talk about the colony stimulating factors. So which positions are frequently alkylated by the alkylating agents? You know, I gave you the positions and you should have it. If you don't have it, ask your friends to donate that information to you. So 2-chloroethyl group meaning monofunctional or bifunctional? Bifunctional. So can you tell me which one of the drugs you remember as a polyfunctional drug? Iotepa, polyfunctional, highly reactive. When the patient is given for the treatment of bladder cancer, the patient is rotated, right? Rotated every 30 minutes. And then when they use the toilet, that need to be flushed and cleaned before anybody else could use it. So when it comes to nitrosoureas, only the first one is bifunctional. The next two are, I'm sorry, not this one. And these two are monofunctional. This is the bifunctional. So remember that. So among the bifunctional, which one of the drugs cannot do this? The name of the drug starts with B. Which one cannot do this? Busulfan, correct. Busulfan cannot do this. It can do only this. And highlight this one. So the DNA repair process in rapidly dividing cancer is not complete. So that is why it is killing them. In the normal cells, DNA repair is rapid, comparatively rapid, and that's why they are surviving, even though they are attacked by the anti-cancer drugs. So now, when it comes to individual drugs, if you have not made up the table, this may be the time to make up the table. You need to remember both generic name, brand names. We eliminated almost, I would say, 40% of the drugs. So your reading load is much, much lower compared to the previous batches. So you should be able to create the table with the brand name, generic name, mechanism of action, indication, combination, and any unique toxicity. When it comes to mechloroethylene, what is very unique in terms of side effect or complication? Thrombophlebitis, right? Cannot be given orally. It should be given only as a slow infusion. Even when it is given as a slow infusion, it is going to cause thrombophlebitis. And combination is MOP combination. So remember that. So this MOP or COP combination, both are good for the treatment of, let me put it back here again, Hodgkin's lymphoma. Both MOP and COP are good for the treatment of Hodgkin's lymphoma. It may be appearing in various listing, and make sure you are picking the right combination for the treatment of Hodgkin's lymphoma. Know everything about cyclophosphamide. know everything about cyclophosphamide? And acrolein, what is the role of acrolein? Does anyone remember what is the role of acrolein? It causes hemorrhagic cystitis, right? So more fluid, use of more fluids, that's one strategy. In addition to that, you are going to be using what else? Mesna, mercaptoethane sulfonate. Can you give mercaptoethane sulfonate long after the infusion of the drug is completed? No. It has to be given prophylactically or during infusion because it has a direct neutralizing effect. It is directly neutralizing acrolein. Also remember, this is important, this aldehyde oxidase level, if it is high in normal cells, that is what is protected because it is deactivating this metabolite into carboxyphosphamide. So remember that. And all the combinations are important. FAM, CAV, and PAC-MAC combinations. So I would say cyclophosphamide is one of the important drugs. Read everything about this drug. So cyclophosphamide is number 3 when it comes to nausea and vomiting. Nausea and vomiting, potential is putting this as number 3 in the listing. What is number 1? Cisplatin. So what is number 2? You don't remember what is number 2? Dacarbazine. So the simplest way to remember is CDC. CDC, cisplatin, dacarbazine, cyclophosphamide. CDC, remember CDC, these are the top nausea, vomiting inducing drugs. CDC. So I said ifosfamide can practically replace cyclo, but what is the risk? The risk is 4 times higher when they use ifosfamide because the amount of acrolein produced is 4 times higher. Melphalan was developed for treating melanoma, but unfortunately it was not very useful for treating melanoma. Instead, multiple myeloma. Multiple myeloma comes only in one place, then this is the place. Multiple myeloma is treated with combination including melphalan. So what else is unique about melphalan? Melphalan can be given orally because multiple myeloma is slowly progressing, and because of that it can be given orally. And when it is given orally, food can slow its absorption, it can impact the bioavailability, and also cimetidine. Food and cimetidine can reduce the bioavailability of melphalan. So look at chlorambucil also, which is for the treatment of chronic lymphocytic leukemia. So that takes us to the next group of drugs called nitrosoureas. So there are 3 drugs you want to remember: carmustine, lomustine, semestine. Can you use semestine for treating brain cancer? If you say yes, you have to go back and read carefully. Semestine can be used only for treating pancreatic cancer. I gave you 2 drugs, not only semestine, gemcitabine. There are 2 drugs. So let me put the information. So this is coming in the next page. This is what I'm talking about. Semestine is used for the treatment of pancreatic cancer. The first 2, carmustine, lomustine, those 2 are for the treatment of which cancer? Brain cancer. Brain cancer. And there are 2 mechanisms. One is alkylation. What is the second mechanism? Does anyone remember what is the second mechanism for the carmustine-lomustine carbamylation? Carbamylation, the thiocyanate produced during the metabolic breakdown of the drug can carbamylate. So there are two mechanisms, alkylation and carbamylation. Bone marrow suppression is very severe. So if somebody is, let's say, showing neutropenia, what kind of colony-stimulating factor would you be using? If somebody is showing neutropenia because of carmustine use, what kind of colony-stimulating factor would you give?
Yeah.
Neupogen, right? Neupogen, and if it is anemia, Lipogen. If it is general, let's say thrombocytopenia,
Yes, sir.
or other types of, generalized blood cell count, white blood cell count drop, then go with Glucomax. Glucomax. Low macrophage count, low platelet count, so Glucomax is what is going to be used. So, when patients are treated with streptozotocin for pancreatic cancer, are they going to be showing hypoglycemia or hyperglycemia? Why they are showing hypoglycemia?
Honestly, pancreas.
Yeah. When the pancreatic cells are destroyed, it releases insulin, which would cause hypoglycemia, which could be life-threatening, so they have to be prepared to deal with that. So that's something unique about streptozotocin. You know the mechanism of action and indications and all that. So thiatopa, we talked about thiatopa, polyfunctional, alkylating agent, and it should be injected directly into the bladder. So when it comes to dacarbazine, know everything about dacarbazine. When the level of 2-aza-hypoxanthine, when the level of 2-aza-hypoxanthine is high in the blood, what does it mean? The drug was exposed to light.
No, it's inactive.
The light, the drug was degraded by exposing to light. So if you see in the plasma of the patient, if you see high levels of 2-aza-hypoxanthine, that means the drug was already exposed to light. Yes?
Was you able to upload a clear version of that onto Blackboard?
Oh, this one clear version? Yes, I will do that.
Thank you.
So I'll send it to Dr. Ansari and ask him to post it. And then this is the methyl group, which is going to be alkylating. So is it going to be bifunctional, polyfunctional, or monofunctional? The carbazine, is it going to be bifunctional, polyfunctional, or monofunctional? Mono. So it should be monofunctional. So if I list dicarbazine and ask you, is it true or false, this is a bifunctional, you should know the answer.
False.
So we talked about busulfan, it's a bifunctional alkylating agent, but it cannot cross-link two different DNA strands. It can be attaching to the same DNA strand. That's what I showed you before. And in addition to that, it selectively accumulates. It selectively accumulates in the granulated cells. So that's why it's used for the treatment of AML and CML, right? Both acute myelogenous leukemia and chronic myelogenous leukemia. Similar to DNR. DNR is daunorubicin. Similar to DNR. I could see that those who were missing the class are blinking, but you have to go back and take the notes and start to read. Pulmonary fibrosis is one of the side effects seen among patients who are 50 or older. Among older patients, busulfan use will induce irreversible. So that is the key, irreversible pulmonary fibrosis. And that is called busulfan lung. So you have that here, busulfan lung, busulfan lung. Okay, when it comes to cisplatin, everything you should know about cisplatin, not only mechanism, activation, also the uses and side effects. Now, this hydration, does it take place in the circulation? Hydration of the platinum complex. Where does it take place? Is it in the circulation or
Cytoplasm.
in the cytoplasm of the cancer cells? So that's very important. So this hydration will take place only in the cytoplasm. After the molecule is hydrated, it can alkylate as a bifunctional alkylating agent. So it says hydration takes place in the cytoplasm of the cancer cells. Now, when it comes to toxicity, kidney damage is one of the most frequently seen side effects. P here stands for platinol. Platinol is the brand name for cisplatin. C stands for what? Cyclophosphamide, right? C. Wherever there is PC, kidney damage. Wherever there is AC, heart damage, cardiotoxicity. So those you remember. Cisplatin can also induce hearing loss. And that was already, in addition to alopecia, nausea, vomiting, it should be saying hearing loss. You see that here? So you may want to highlight that. Hearing loss is one of the unique side effects coming with the long-term use of cisplatin. So I would ask you to look at the top 3 drugs. I also mentioned that only 2 drugs in this category, which are pentostatin and cytarabine. Pentostatin and cytarabine are called antimetabolites. Everything else is what type? Excluding pentostatin and cytarabine. The rest of the drugs belong to which category? Alkylating agents. Good, alkylating agents. So when it comes to management of nausea, vomiting, I gave you the list of at least the 3 anti-citron agents: ondansetron, granisetron, dolasetron, palnositron. So you have the brand names. The combinations are ZAD and CAD. ZAD and CAD. Okay, amifostin. What is the use of amifostin? It's an aminothiol drug. It's activated by which enzyme? Phosphatase. It is activated by phosphatase, which is high in normal cells. So, for example, if somebody is developing kidney damage, amifostin is used to minimize the kidney damage. In the normal cells, amifostin is activated. It is not activated in the cancer cells. If it is getting activated, if amifostin is getting activated in the cancer cells, it will compromise the therapeutic effect of cisplatin. So you don't want that to happen. You want this to happen only in the normal cells. That's possible because of the phosphatase enzyme, which is present. So that was discussed in the class. I'm just kind of rebrushing your memory. So when it comes to antimetabolites, methotrexate and 5-fluorouracil, everything is important. Carboplatin, I mentioned about carboplatin. You're not going to have any questions related to carboplatin, but when it comes to antimetabolites, know the general characteristics. What are the general characteristics? GI damage is one of the common characteristics for antimetabolites. Stomatitis, esophagitis, colitis, ulceration of the stomach. So those are common because the GI is damaged. Specifically, almost all drugs which belong to this category are S-phase specific. And I made it very clear in the question, if I list 5FU, okay, let me not talk about 5FU. So this is the pathway where two drugs are working. Right now we are focusing on methotrexate, which inhibits what enzyme? It inhibits dihydrofolate reductase enzyme. And if you look at protein binding, about 50% of the drug is bound to the proteins. So what is number one in terms of showing protein binding? Number one is cisplatin. So this you can say number two. Number two, when you are using salicylate, which displaces methotrexate from plasma albumins, which will increase the bioavailability. Same way, other drugs which are binding to plasma proteins can also increase the bioavailability, which may not be good all the time, so it may be causing side effects. So, resistance is listed here. The three specific mechanisms are listed here. Elevation of the target enzyme. Whenever the level of dihydrofolate is elevated, that is resistance. Mutation within the binding site of the enzyme, so that is resistance. And reduced transport. Transport here is the uptake process. Reduced uptake is resistance. MAC combination, both methotrexate and its metabolite are nephrotoxic. They cause kidney damage. And when it comes to rescue, leucovorin rescue is very commonly used. And which enzyme is helpful in doing this rescue? Isomerase, right? Formyl tetrahydrofolate is converted to methylene tetrahydrofolate. I'm not going to be testing you on that reaction, but that is where this isomerase is needed. Where do you find isomerase? In the normal cells or cancer cells? Normal cells. Normal cells. So similar to the phosphatase. Phosphatase is helping amifostin. Here, isomerase is helping leucovorin. What is the difference between Mesna and leucovorin in terms of administration? Is there a difference? Yeah, leucovorin can be given even after the completion of the IV infusions. It can still help to, kind of rescue the normal cells. The damage can be repaired, whereas Mesna cannot repair the damage. It can only neutralize the drug. So when it comes to 5FU, remember that active metabolite is, what is active metabolite? This 5-DU-MP is the active metabolite. The parent drug is not active. I mentioned that very clearly during the class. So if I list 5FU, 5-DU-MP, and DU-ATP, DU-5-fluorodeoxyuridine triphosphate, the inhibitor is deoxyuridine monophosphate. What is being inhibited by this deoxyuridine monophosphate? Thymidylate synthetase. Thymidylate synthetase is inhibited, so that is the primary target, leading to what kind of death? Thymidine-less death. Two drugs can induce that. What are the two drugs? One is 5FU, you know that. What is the other drug which can cause? Methotrexate. Methotrexate. Both can cause thymidine-less death. In addition to inhibiting the thymidylate synthetase, it can incorporate. This is called fraudulent incorporation. Fraudulently incorporate because of the structural similarity into RNA and cause nonsense RNA production. which will kill the cancer cells. Resistance, again similar to method, the dihydrofolate reductase. Here also, elevation of the enzyme can cause resistance. Mutation, and also the enzyme which are necessary for activation, like uridine kinase. Level of uridine kinase will be lowered by the cancers, and that causes resistance. So what cancer is treated by using 5-fluorouracil or the combination containing 5-fluorouracil, colorectal, FAM combination. FAM combination includes 5-fluorouracil. What does A stand for what? Adriamycin. M stands for mitomycin. So 5-fluorouracil is thiamidylate synthetase inhibitor. Adriamycin is a topoisomerase inhibitor, also DNA fragmenter. Mitomycin is, you should have that in the notes. Mitomycin is an alkylating agent. What is the risk in AM combination? What is the risk in AM combination? Higher cardiotoxicity. Mitomycin will potentiate the cardiotoxicity induced by adriamycin. Whenever you look at adriamycin, always remember it will cause cardiotoxicity. So RSC need to be converted to RSCTP. That is the form which will be inhibiting the DNA polymerase. You know, it may say in some literature, it may say it inhibits the reverse transcriptase. You know, yes, that can also happen, but inhibiting DNA polymerase is the primary mechanism of action. So when it comes to resistance, deamination, removal of the amino group. I said deamination. Oh, let me move it here. Deamination, and that removal of the amino group will be inactivating the drug. In addition to that, depleting the kinases, cytidine kinase and diphosphate kinase. Both, when the levels are lowered, it lead to resistance. The use is for treatment of what cancers? Myelogenous leukemia, CML and AM. Now, which other drug was used for similar indications? Busulfan. Yes, busulfan. Okay, I said mercaptopurine is important drug. Not only mercaptopurine, thiaguanine. 6-mercaptopurine, thiaguanine are important. These are pyrimidine analogs or purine analogs? Purine analogs. So when you give purine analogs, what side effect is going to be expected? What kind of side effect is going to be expected whenever you give purine analogs? Let's say you are treating acute lymphocytic leukemia patient, children, and you are giving 6-mercaptopurine. Yeah, right, uric acid accumulation, yeah. And in addition to that, we talked about the polymorphism. What polymorphism do you have in your handout, in your notes? TPMT polymorphism, thiopurine methyltransferase polymorphism, right? They have to test for TPMT polymorphism. If they are positive, that means they are poor metabolizers. Poor metabolizers will accumulate the drug, and it's lethal for children. You're talking about treating small children, it could be lethal. So it has become a common practice. Not only it's common, it's required that children should be tested for TPMT polymorphism before they are treated. So both drugs are activated by hypoxanthine guanine phosphoribosyltransferase, HGPRT. That enzyme deficiency would make these drugs inactive. Not inactive, useless. The parent drug is not going to be phosphorylated. Remember, I said MP, 6 mercaptopurine monophosphate. So that is the form which is going to be active. 6-diaguanine monophosphate. That should be in your notes. So the monophosphate forms are the ones which are going to be, depleting the levels of adenine or guanine. So when it comes to the miscellaneous drugs, I only gave you gemcitabine, ribonucleotide diphosphate reductase. RDR, ribonucleotide diphosphate reductase, is the enzyme inhibited specifically by gemcitabine. It's another drug for the treatment of pancreatic cancer. So you should have pancreatic cancer as the indication highlighted here. So only 2 drugs are listed for you so far for the treatment of pancreatic cancer. And then when we were talking about anti-tumor antibiotics, I skipped several pages and we talked about daunorubicin. Daunorubicin can be used only for the treatment of leukemias. It cannot be used for the treatment of solid cancers. It cannot be used for the treatment of breast cancer or thyroid cancer. Remember that. This small difference. If it is daunomycin, this R is going to be a methyl group. If it is adriamycin, it's going to be CHOH. Even though there is very small difference in the substitution, when it comes to the effectiveness, DNR, daunorubicin, is only useful for treating leukemias. What is the primary mechanism of action? So, did I say it is an intercalator? So, here it says intercalation, right? Intercalation is the primary mechanism of action. And then, do you have anything else listed? I would have said it is also inhibiting topoisomerases and also causing DNA fragmentation. So, number 1 is intercalation. So, I said, I did mention about Donazome. Donazome is a liposomal formulation. Basically, they put the drug in the liposomes to reduce the toxicity. Both doxorubicin and daunorubicin induce severe cardiotoxicity, and by putting them, Doxil is the formulation that includes doxorubicin in the liposome. Donazome is the liposome with daunorubicin. Both of them are made as liposomal formulations for reducing the cardiotoxicity. Okay, when it comes to dox, know everything about dox. Adriamycin. Know everything about adriamycin. The primary mechanism of action is topoisomerase inhibition. Number 2 is DNA fragmentation. Number 3 is intercalation. Intercalation can be minimal. So these are the combinations that are used. CHOP and ABBD are something new compared to other combinations that are listed. So the main thing I mentioned about doxorubicin, women who are treated with doxorubicin should not be breastfeeding the babies. Why they should not be breastfeeding the babies? The level of the drug in the breast milk is same as the level that can be found in the patient's plasma. If it goes into children's body, they are going to damage the heart, and that's why women are not allowed to breastfeed the babies. So we talked about Doxil, Donazome and Doxil. These are the liposomal formulations, including doxorubicin. And after that, I skipped many other drugs, and then I briefly mentioned about the mitotic spindle poisons. So the mitotic spindle poisons are, no, not this one. The mitotic spindle poisons are vincristine and vinblastine. Since these two drugs are already included in that cell cycle, showing that they are M-phase specific drugs, you're going to remember where they're working. Both are interfering with the mitotic spindle formation. So in a simple sense, I'm going to say not allowed to add any new information during the review, so I'm kind of restating the mechanism that was given to you during the class. So both will be interfering with the mitotic spindle formation, which will be blocked. This way DNA, the chromosomal separation is going to be blocked, cell division is stopped.
I agree.
And then what else? Taxol. Finally, I said Taxol is also coming from originally it was coming from the plant. In terms of mechanism of action, Taxol will be doing what? It will be stopping the breakdown of the mitotic spindles. Vincristine, vinblastine will be blocking the spindle formation. On the other hand, Taxol will be stopping the fragmentation or breaking down of the mitotic spindle. All these drugs are good for treating ovarian cancers or testicular cancers. I said genital cancers. Genital cancers can be treated by using Taxol, vincristine, vinblastine. In addition to that, there was something else I mentioned. I don't remember it now, but maybe it's not very significant. Taxol would induce multi-drug resistance. So that was covered before under the pre-glycoproteins. So these were the things that were covered. In addition to this, I gave you, you have that handout, pharmacogenomics handout in the blackboard. Have you seen that handout? If not, go back and see it. If you don't see the pharmacogenomics handout, I will ask Dr. Ansari to post it, because under that, there are 4 drugs. Number 1 is 5-fluorouracil, number 2 is irinotecan, and then 6-mercaptopurine. So these are the 3 drugs at least you need to focus on. What polymorphism and what is the consequence? So in the class, I highlighted the polymorphism. TCEP, for example, TCEP for polymorphism is related to 5-fluorouracil, and individuals with TCEP polymorphism are poor metabolizers. TPMP polymorphism, that is also indication of poor metabolism. And then under irinotecan, see what is the conjugation and what is the name of the conjugate, and that might be helpful in answering one of the questions. So that concludes everything that is going to be included in the exam. If you have any specific questions, if that is something that is going to be benefiting the whole class, I want the rest of the class to be quiet. If you're not asking any question that is going to be benefiting the entire class, you can catch me. I'm going to be available for the next 30-40 minutes. So good luck and study well, and you will be able to score well in the exam. Yes.
Thank you so much.
Thank you.
Thank
You're
you
very
so
welcome.
much.
Somebody have a question? You have a question?
Prince, when you lose,
Oh, how
upload
many
it
questions?
actually.
It's going to be worth 96
the crocodiles
points,
again.
48 questions. 48 questions.